Good afternoon, everyone. So I'm John Green. I'm part of the HomeLink team. And this is Jo Probert, who will tell you a lot about her when she gets onto her piece. What we're going to talk to you today is about HomeLink and a little bit about the HomeLink journey and who we are. But we're also going to talk about our partnership with James Paget, where Jo is the clinical lead, and how we've developed that partnership over a number of years and how that has developed. What I will say is we're probably unique amongst the private providers here in that we don't do technology. We're not a technology company. We deliver care, we deliver the nurses and the clinical teams into the home. And I think that gives us a slightly different viewpoint and a different perspective on how virtual wards operate, because we take the view, like I'm sure a lot of the NHS teams here, that we start with the patient and put the patient at the centre of what we do. And the technology that we work with, we're agnostic to what technology we work with, is a little bit incidental. It is part of the story and part of the journey, but it's all about how we support that patient on the journey itself. Oh, hang on, we're working our way through far too quickly on the slides. I'm sure I'll work with technology in the end. I told you we didn't do technology, didn't we? Who are we and where's our background? So HomeLink, and you'll see from some of the bits on the slide there, we probably were doing all of this before it became in vogue. So we've been in existence since 2016. We were very much hospital at home services, and we delivered hospital at home services pre-pandemic, and delivered the sort of things that you will see virtual ward. And we are, or we like to describe ourselves at least, as a private NHS organisation. We're very much clinically led. Our chief executive is a nurse who very much sticks by her nursing principles, and there's a real focus about how we work in partnership. And the most important thing for us is getting the governance and getting the safety and getting it right for the patient. And yes, we happen to have contracts and we happen to get paid for it, but they're almost incidental in terms of how we will approach. And hopefully when we talk through our journey with James Paget, you'll see that very much is how we've approached things. We don't just do what I would describe as the boots on the ground for virtual ward. We deliver a range of services from support from admission avoidance, discharge to assess, therapy services. We will also work with GPs in anticipatory care, and we're a wholly employed model that is across a number of places across the country. And I think if we look at those services across different places in the country, what is special about them is that every single one of them is different, because everyone's problems are slightly different. And we'll have the saying that everyone is different, but no one's special. And that is very obvious when you go and visit a service or visit a hospital. And therefore, we will flex whatever we need to fill that gap and to support the service in its overall delivery. There is nothing that we do that is unique. There is no reason why it can't be done. We just have a lot of experience of setting up services, setting them up quite quickly. And if that means it gives you a couple of years to set up and develop that workforce, we're very happy at the end of those 2 years to go, great, you've got it. We'll go and move on to the next place. You can now deliver that service locally. And I think that's a really important ethos to have as an organisation and as a company. And hopefully we'll see a little bit of that with the James Paget. So the story behind James Paget was we were already delivering services in the neighbouring trust at Norfolk and Norwich, and had been doing for about a year. It had been a mix of IVs, some dressings, some bridging services, and Paget asked us to come in off the back of a little bit of winter money. Remember those days? A little bit of winter money that was left over at the beginning of 2020, and they wanted us to deliver a service that was a mix of a little bit of admission avoidance. They wanted us to work with some weight-bearing patients, or non-weight-bearing patients, and a couple of other fairly minor pathways. We did our mobilisation, working from January all the way up until go live date on the 20th of March. 20th of March 2020. There were a few things going on at that particular week when we started our service, and therefore we kind of started and didn't start. But we had a contract and we wanted to work in partnership. And what we ended up doing was saying, you bought a number of visits. Our contract says we'll deliver those over the next 4 months, X number of visits. Clearly that's not going to happen. But we wanted to continue to work in partnership. And we think probably September time, you're going to have a real need for us. So we will support you in any way that you want. We'll continue to do a few visits because there were still a few things that were needed to be done. We'll support you in whatever you need to do. If it meant that visiting COVID patients in their home, we would go and do that. And we did that for 6 months at about probably a 25 to 30% of the activity that they'd commissioned. At the end of that, they went, you remember it well, I'm sure, all of you. The floodgates reopened. The world didn't really turn back to where it was, but suddenly there were patients coming in and their patients couldn't get out because of all the restrictions. And that's how we started off, and that's how we started working through. Very shortly after that, we then moved into, because we were already running a virtual ward, one of the first ones up at Norfolk and Norwich, we then moved into how we were setting that up with the James Paget. And Jo is going to tell you all about that.
I will. Hello. So I'm clinical and operational lead at the James Paget. So basically, as John has explained, we are an independent service that are commissioned by the James Paget to deliver a certain number of visits a week. And I have a workforce of 14 nurses and 2 healthcare assistants that work within the community. So alongside the virtual ward, we deliver IVs that we can do either once a day up to 3 times a day. We can deliver blood tests. We also support with the at-home monitoring. So say, for instance, a patient is at home, they're struggling a little bit with their monitoring system, we can also go in and support with that. We've also started some new pathways, so we've just done negative pressure, so the VAC dressings in the community. We've just had our first cardiac patient for our cardiac pathway, and we are already in talks of oncology and haematology at home. So I've done a little patient story as well, just to kind of the flow of what happens. So a patient's admitted to A&E via an ambulance, 69-year-old, presenting firstly with abdominal pain. After investigations over several hours and the past medical history of MIs and asbestosis. So the patient then gets transferred through to EADU, which is a lot of your MAU. And the final diagnosis is he has CCF with overload. So he goes up to CCU, and then they realise that actually, can this patient go home? He has a wife at home that he cares for, so he really doesn't want to be in the hospital. They go through to virtual ward, have a discussion with them, they accept him, and then they come to us to see if we are willing to deliver the frusemide IV for 3 days. We accept. The next process is we'll go in, we'll do an assessment on the ward to ensure that they are aware of what is going to happen when they're at home. Are they safe to be at home? And do they consent? And is this the best thing for them? So it was agreed that yes, he was. By the next day, he was home. We then delivered the 3 days of IV frusemide. He continued to have the monitoring kit through virtual ward and daily phone calls, and then we went in to take blood tests. I do not have his outcome measures today because he's been discharged this week. He is doing very well, he's stable. We do know that he has outpatient appointments to follow up, obviously his cardiac issues. He was very grateful to our service. In his words, I wasn't stuck in a hospital bed. So a very good outcome for him. So data. What does data show? We all love data because it proves that things are going really well. Every month we will do a trust review with the James Paget, and we will present our data. And the meaning of that data is to show the improvements we're making on the patient, the beds that we are saving monthly, the cost that we are saving. You can see on this slide that over the 4 years that we've been the James Paget, we've actually saved 21,000 bed days, which is pretty amazing. So again, it's all about client satisfaction for us. And on the next slide, you will see what we like to do is throughout the journey with our patients, we will encourage them and their families to complete short surveys for us. At the end of their treatment, we will also encourage them to complete a longer survey with honesty, because obviously if we need to improve, that's what we want to do. And we also encourage our clients to complete surveys for us. And as you can see, we've got some very nice feedback. So one of them is, as a partner organisation in the care of our patients, it has been both rewarding and exciting to work alongside a team, and it's disappeared, work alongside a team that are equally committed to improving patient journeys. A lot of the patient feedback is always, it was so nice to be at home, because we're preventing some of these patients from being in hospital for 6 weeks plus, where they need IV antibiotics. To you, John.
Thank you, Jo. So, one of the things that we like to focus on is building that trust. And you'll notice Jo talked about, we go and do the assessment, we go and meet the patient on the ward, we have the discussion, and we are embedded within the teams. And I think there's been huge investment in virtual ward. Admittedly, that's a little bit flatlining at the moment. But if we look at the numbers from the latest NHS England data, the number of increased beds is also flatlined, as has the occupancy levels. And clearly, we want the virtual wards to be as full as possible, because that's how we're going to make it really work. You'll notice from there that our virtual ward, or from the number up there, our virtual wards are almost totally full. At 97%, there's a little bit of variation within there. You'll see that the number that Jo put up there, they're running at 99%. And I think part of that is how we're set up and how we're commissioned. Obviously, it's slightly different from you set up a ward with a certain number of beds and therefore it'll be filled as you go. But I think some of the things that we do differently, so you'll see there that it's 4 to 12 weeks in terms of a mobilisation. That's quite a long time. 3 months mobilisation, most people will say, why does it take so long? Part of that is you have to build trust. You have to make sure the governance is right. You have to make sure the system's in place and the pathways are clearly understood before you put patients into the system and put them into the virtual ward or the home environment. And I think that understanding of taking your time at the beginning to set it up, we've done this for a lot of years, and we've done it for virtual ward, for hospital at home, for discharge to assess, for a number of different areas. Having that set up at the start is really, really important. And our aim as we highlighted is to get that satisfaction right and to keep that safety. But what are some of the things that we do that are not unique to us, but what we will focus on and where we think our magic sauce is? And some of this comes out from the NHS behavioural unit that looked at why do some virtual wards struggle to have high occupancy levels, and it's built around that. First of all, you have to build trust. You have to build trust within the system, and you'll see some of the things that we do there. If I was highlighting one, I would say it's our clinical teams are on site, and they sit alongside the consultants, and they sit alongside the matrons and the ward managers and the nurses, and therefore you build that trust over a period of time and build that understanding. And I think that's really important, that there is that two-way understanding. Confidence comes with time. It just doesn't arrive. But you also have to have confidence, and we would say this as a commercial organisation, it's different if it's your own teams or your own NHS staff. You have to have confidence in that our processes are good, our clinical staff are well trained, and have the right attitudes and background that you would wish them to. And probably the most important is also, how do you manage risk? Because if you're not managing a risk, you're not going to build the trust. And therefore building that risk management environment, which goes back to the mobilisation I talked about, But also, I think one thing that we do, which is relatively unique to us, we will run a 24/7 on-call service. So anyone in that virtual ward will be able to contact back into us at any time to be able to know where they can go to. And building some of that security blanket and network is really important for building that both trust, the confidence, and ultimately because it's you're managing the risk. So the last slide just is a very wrap-up of HomeLink. This is what we do, and this is where we're proud of in terms of we're tech-enabled, but we're not tech-led. That we make sure we work in partnership. We're small, but it means that we can be agile and we will work with you to solve problems. It's got a mind of its own, isn't it?
I know.
Oh, go on, I'll click it back for one, why not? But if I was to summarise, what I would say is we focus on making sure that we improve health outcomes and that we improve patient satisfaction. As a side benefit of that, we also deliver it for value for money, and you saw that through some of the costing models there, but also we help to improve performance because we help to improve flow. And as an ex-chief executive and an ex-coup, if someone had come to me and said, I can do this for better value for money, improve your performance, and it improves health outcomes, and improves patient satisfaction, I'd have bitten their hand off, because surely that's the utopian position we want to get into. Thank you very much for listening.
Thank you.